This video presentation and its accompanying materials are copyrighted by the American Association for Respiratory Care, AARC. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. As a registered participant, you are authorized to duplicate course materials for this program for each participant viewing at your facility. This presentation and accompanying materials can be used by staff within the institution but cannot be resold, distributed, or displayed for profit. Copyright 2018, all rights reserved. The following is a presentation of the American Association for Respiratory Care. Welcome to Current Topics in Respiratory Care. Today's topic is Evaluating the Value of the RT. Where is the evidence? Dr. Marin Kollef is Professor of Medicine at Washington University School of Medicine and is Director of Respiratory Care Services and Director of Critical Care Research at Barnes-Jewish Hospital in St. Louis, Missouri. Dr. Kollef discloses relationships with Academy of Infection Management, Accelerate, Allergan, Aridis, Arsenis, AstraZeneca, BioMaru, Cardeas, Forest, Merck, Medicines Company, Paratech.
Thank you very much, Dean. It certainly is my privilege to be here today. I really want to thank everyone for getting up on a Saturday morning. That's really something to attend this morning. What I'm going to do today is just talk a little bit about the evidence in support of respiratory therapy, the profession, what's the evidence there. It's really sort of a follow-up to a manuscript that Dr. Stoller published in Respiratory Care almost 10 years ago. And I'm going to try to continue moving forward from that point. One thing I will say is that a lot of this will be based on my personal experiences at Barnes-Jewish Hospital and the privilege I've had of being the medical director of respiratory care services there over the last almost 20 years. You've already heard the objectives. I'm going to try to go over some of the evidence supporting the value of respiratory therapists in the medical community, primarily inpatient, but also outpatient. I won't be able to cover everything this morning, but I'll try to at least offer some introductory comments on this topic. I'll talk about how respiratory therapy has been able to improve healthcare, and very importantly, try to identify areas for future research. I think we all understand, whether we work in the outpatient environment or the inpatient environment, that it's really a team approach. In the hospital, in the emergency room, in the ICU, we all sort of recognize these teams that get together. Timing is of the essence when it comes to managing acute problems, things like a cardiac arrest, someone who has sepsis, a stroke. But even more mundane things really require a team approach and having a very organized focus for that. Whether it's a patient who might be deteriorating on the floor, an outpatient who we're trying to avoid having to come back into the hospital, someone who's going through pulmonary rehab in order to try to increase their likelihood of doing well with a surgical procedure. These are all teams that get together, and certainly respiratory therapy plays a very important role in all of those teams. Sometimes it's not as well recognized, and that's where the research part comes in, and I'll show some examples of how that can be done. These are just some of the topics I'm going to cover this morning, talk a little bit about procedures, really spend most of the time on how respiratory care professionals have helped develop important protocols and guidelines for the management of patients, both on the inpatient and outpatient side. Disease management programs, something that increasingly we're starting to see, yet there just hasn't been as much research in this area or development of this area as we would like. And really finish off with a word or two on rapid response teams. So procedures are something that commonly occur both in the inpatient and outpatient arenas. Respiratory therapists do procedures, we all recognize that. There's variability from hospital to hospital in terms of the types of procedures, the quantity of procedures that are done. I thought I would only really focus on a couple of them, but just to highlight them as areas where we probably need more work and more development in terms of developing this area. This is just from a survey that appeared recently in Respiratory Care. I thought it was a very interesting survey talking about intubation I did all my training in Army hospitals. When I was in the Army, we had the capability of having respiratory therapists do intubations, do other procedures. Many of them functioned as medics when we would deploy. They also had to carry out those roles in the deployed area. But in this particular survey, it was interesting because they contrasted the respondents who were respiratory care practitioners in terms of whether or not they performed endotracheal intubation or did not. And we all know that hospitals vary. But the larger hospitals were the ones where they were more likely to do it, and these were primarily larger non-academic hospitals. And in part, they were really serving a need or a function in those areas. And that had to do with the fact that in some of these community hospitals, they didn't have someone in-house 24/7, or they may not have had enough individuals in-house, let's say anesthesia. So respiratory therapists had to be trained in order to carry out those procedures, whether it was a direct endotracheal intubation or using something like an LMA. And you can see here that regardless of whether or not they did these intubations in-house, the therapists felt that they could safely do it. And more importantly, if they were doing them in-house, the respiratory therapists felt that they could be primary providers of this procedure. So it's just one example, just indicating that it can be done, that there's variability, and we probably need more information on this particular topic. An area that we developed over almost now 20 years ago was the idea of doing mini bronchoalveolar lavage. And this was a study we did at Barnes-Jewish Hospital where we took patients in the ICU on mechanical ventilation, and the idea was that you could have a non-physician do a lavage using a telescoping catheter, and that it was really going to be, and the hypothesis was that it would be at least similar in terms of the results compared to what we would do with a fiber optic bronchoscope. And what you can see in the top graph here were that the side effects, if you will, or complications were comparable between the two. There really weren't major differences between the two, whether it was a blinded mini BAL done by a respiratory therapist or a formal BAL done fiber optically by a physician. And then when we looked at the results at the bottom in terms of the cultures, the quantitative cultures that came back primarily to try to either rule in or rule out a diagnosis of pneumonia, they were the same. So here we demonstrated that this useful procedure could be done, it could be done safely, we could get accurate information back, and just another example where we could expand the utility of respiratory therapists. And in fact, more and more now with this idea of antimicrobial stewardship, there's a need for these kinds of data in the form of cultures in order to help us control our antibiotic use. And we all know that antibiotic resistance is a growing problem, not only in this country, but globally. At Barnes-Jewish Hospital and in many hospitals around the country, respiratory therapists play an important role in support of the conduct of complex procedures, whether or not they be fiber optic bronchoscopy, percutaneous tracheostomies, et cetera. And they play a role in terms of controlling the procedure, performing bronchoscopies, particularly for the guidance of percutaneous tracheostomies. So that becomes an important role and value in that team approach. This is just the bronch room here, and what I'll tell you without question, if you talk to any of the fellows at Washington University and Barnes-Jewish Hospital, and this is true of any training program around the country, a lot of the questions they have are frequently directed at the respiratory therapists. And although I picked the example here of bronchoscopy because they're working with experienced therapists who've been in this field for more than 10 or 15 years, the same is pertinent when it comes to non-invasive ventilation, the use of mechanical ventilation, how to adjust the ventilator, the different settings. So there's an important training role that the therapists play in terms of not only training future therapists, but also physicians as well as pulmonologists. I'll move on to the next topic, and this is an important one, and it's one that I think respiratory therapy has helped to develop over the last 25 years. Maybe more so than many other specialties. And that's the use of protocols to help to guide therapy. Not just guide therapy, but actually to optimize it. I show this picture because I was a member of the Ebola team, not because I wanted to be part of the Ebola team, but I guess I was the oldest person there, and I thought, well, if he dies, at least he's had his kids, and we don't have to worry about him, we'll sort of save the younger people for later. But, when you're part of an Ebola team, let's say, you have to learn how to put the gown on, all the equipment on, there's a protocol. And the protocols are meant to improve outcomes, standardize the procedure. And, obviously this is true in many settings. I'm not going to go through the details of this weaning protocol. This was a weaning protocol that we developed back in the mid-1990s. It was interesting because when I got to Barnes-Jewish Hospital in 1992, couple of years after that, I became the medical director of respiratory therapy. Barnes-Jewish it was Barnes Hospital at the time, and Jewish merged. And I can remember sitting down, I think Patty was there, Darnetta was there, and we sort of started talking about, should we try to standardize the way weaning is done amongst the different ICUs in the hospital? Because we had multiple intensive care units, we knew that things were being done differently in a way to try to sort of optimize things. Because the goal here is to get the patient off the ventilator sooner. I mean, it could be something different. It could be pulmonary rehab in the outpatient setting, where the goal is to strengthen that patient's capabilities, increase their pulmonary endurance so that they can maintain, their pulmonary function over time. But in this particular case, we were focusing on a protocol to try to optimize weaning from mechanical ventilation. And it's a pretty standard approach. I mean, I'm sure you all have very similar protocols. We have changed them over time, and they've been optimized over time. But the key thing was, putting it together and having an approach. And so once we sat down and agreed that, this was sort of the template that we wanted to follow, we had to decide on, okay, who's implementing it? And who better to implement it than the respiratory therapists in the ICU at the bedside? And so here we can see this almost 20 years later, where it's being implemented on a routine basis. And I think we've understood now that whether it's a weaning protocol or some other therapy-based intervention, having it done in a more systematic way is more likely to not only improve efficiency, but improve the outcomes. Those are clinical outcomes, financial outcomes, et cetera. Now, from that particular study that we did, it was very clear to us that once the protocol was implemented, compared to physician-directed weaning, that the patients spent less time on mechanical ventilation. That was simple. The time to the first spontaneous breathing trial was reduced. The time overall for mechanical ventilation was reduced. So that really becomes a win-win, because there were no downsides from that. Patients were not at increased risk of having other complications as a result of implementing that type of a procedure. And this just shows that, having the respiratory therapists carrying out, developing the protocol resulted in less time on mechanical ventilation. Not only that, but we know that technologies are evolving. I mean, this Congress, and I don't know if the booths are still set up, but there are lots of new technologies. Every year there are newer technologies at our hospital. Just recently, in fact, at the system level, there was a group meeting about the development and implementation and what new ventilators would be brought into the system. So technologies are evolving. And so respiratory therapy has to evaluate those therapies, bring them in, and more importantly, figure out how to use them to get maximal benefit from them. And this was also from almost 15, 16 years ago, where at the time, we did this pilot study where we said, okay, we know weaning protocols work. Can we actually use technology to further assist us in their implementation? And it was just using CliniVision at the time. I don't think it's really available anymore, but the idea here was that simply having a reminder that the patient needed to be weaned from the ventilator, that a spontaneous breathing trial had to be done, added to further efficiency in carrying out the weaning process. So again, we can see here the important role of respiratory therapists in terms of moving this whole process forward, with the goal being to optimize the care for the patient. Now, that kind of information was really taken to heart. And this is from an evidence-based meeting that was chaired by, and it was supported by a number of organizations, including AARC, ACCP, ATS, et cetera. But it was a clinical practice guideline. And the guideline was really set forward to demonstrate the utility of weaning protocols that were not implemented by physicians. Because keep in mind that before these things started to be put together, and I remember this as a resident and a fellow in an Army hospital, you'd have to go in, and every time there was a change in a ventilator, write an order. You couldn't really give a verbal order, although sometimes we did it. So it was a very tedious process. But protocols that were put together by the team, carried out by the respiratory care practitioners at the bedside, really made this whole process much more efficient. And this was just some of the evidence. These are the studies. There were both observational studies, randomized controlled trials, including the one from Wasili, who chaired this group, making the point that they worked. Not only did they work in terms of reducing time on mechanical ventilation, but they were safe. And as a result of this, and I think this still holds true today, there were several mandates that came out of this. And I've highlighted them there, and it's still a very useful document, even though it was published back in 2001. And you can see here that the mandates for these protocols are that the protocol use evidence-based methods, which obviously, we all try to do, acknowledge the need for a change in culture. I think this is really key. And I'll show you an example from the study that Mike Komplis had recently, that there still are opportunities to change culture. There are too many hospitals, too many institutions, I think, that still have a very archaic way of doing things. And even the idea of implementing protocols, decentralizing decision-making is still something that is held back. It's certainly held back in many other parts of the world, but even within hospitals in the US. So this idea of changing culture becomes very important, and it usually means having some type of a steward who's going to lead the effort, and that steward or stewards are usually individuals from the administration, from respiratory therapy, from other parts of the hospital getting together to move the process forward. We can also see here that local experts are key. And I think this is something that needs to be emphasized, because when we start talking about improving the quality of care, whether it's through implementing protocols, standardizing practices, looking at new treatment modalities, one has to have a certain expertise that's developed over time to help foster that and carry it out. And most importantly, as a team, establish goals and set objectives. And I think that really is a key aspect of this as well. So it's a very nice document. It illustrates, how these things should be done, can be done, and it's still pertinent today as it was back in 2001 when it was written. So this is a recent study, and I found this study interesting. It has to do with the use of ventilator-associated events. It's a term you might have heard that the CDC, CMS, the government, if you will, is looking as a quality indicator for patients in the hospital, specifically in the ICU on mechanical ventilation. And the idea is that, a VAE is nothing more than a change in a PEEP or change in an FiO2. If they go up, it indicates that some type of problem or complication has occurred. And they are considering using that as a marker for, defining quality of care and comparing one hospital to the other. There are lots of problems with it. I was just at the ID meetings this week where I spoke against this as a quality marker. But if we accept it, this particular study was one done where they took 12 hospitals, more community hospitals, not academic, and 8 control. So there were 12 intervention, 8 control. And in those 12 hospitals, they said, okay, we're going to implement weaning protocols and sedation protocols. Weaning protocols typically, mandated, carried out by respiratory care practitioners, and then the sedation protocols too. So, this was done back in 2014. You would think that by 2014, these things would be optimized. But as the study shows, and the x-axis is over time, it's about an 18-month period there was a significant increase in the utilization of spontaneous breathing trials, as well as spontaneous awakening trials in these intensive care units. Now, that's important because what you can see is that as the use of spontaneous breathing trials and awakening trials increased, over that same time period, there was a reduction in a number of things, including the occurrence of the VAE. But more importantly, time on mechanical ventilation fell off. So it's really that outcome that's the main outcome that we're focused on and interested here. But the point is, and the thing that I think escaped a lot of individuals when they reviewed this was done in 2014. It still illustrates for us, I think, the importance of re-looking at how we do things. And this is where respiratory therapy really can step in and really lead the pack, if you will, particularly not just in the ICU, but in other areas. And although I'm an intensivist and I've spent the last 30 plus years working in the ICU, obviously respiratory therapy is broadly placed and has areas outside of the ICU that may in many regards even be more important, but it just illustrates there's still important work to be done and an important role. I'm going to take another example here, and again this is also from Barnes-Jewish Hospital, illustrating the pivotal role of respiratory therapy in improving the outcomes of patients. And this has to do with the emergency department. I think for a long time we all thought, maybe less so hospital administrators, that the hospital is set up in these compartments. You've got the emergency department, that's sort of the input. You've got these outpatient clinics that send patients through the emergency room into the hospital. You've got the hospital itself, and then eventually the patient leaves. But the reality is it's all one continuum. And that's also true of respiratory therapy. I mean, even within our own department and with yours, you've got individuals that focus more in the clinics, in the outpatient area, in the hospital setting, doing rehab, doing procedures, et cetera. So there's a whole continuum there. But that idea of a continuum hasn't really caught on when you look at it more broadly from a healthcare system. It's starting to. In this particular case, the idea was that we know that the emergency room is where most of these patients sort of funnel in that make their way into the hospital, at least the ones that are acutely ill. And for those that end up on mechanical ventilation in the emergency room, they end up going to an ICU. So there really is that continuum between the emergency department and the ICU. You've got different doctors down here in the emergency department, different physicians and nurses up here in the ICU. But respiratory therapy is really continuous throughout that system, if you will. So like the weaning protocols, there's an opportunity here for leveraging that in order to improve the practices and the outcomes for these patients as they move from one area of the hospital or the healthcare system to the other. And in this particular study, which was the LOVE ED study, which was a LOVE lung protective ventilation initiated in the emergency department, and I'm not going to go through all the protocol specifics, but suffice it to say, this was done, the person in charge of this, if you will, was Dr. Brian Fuller, who's one of our emergency medicine critical care physicians. But the key individuals involved with this were the respiratory therapists working in the emergency department, because they were involved with the development of this protocol and, most importantly, carrying it out and seeing and monitoring that it was fulfilled within those patients in the ED. And it was pretty straightforward. You had to measure how long these patients were. You had to figure out what an optimal tidal volume for them was. You needed to keep the head of the bed elevated. You needed to set an FiO2 and a PEEP that were reasonable and go on to the next patient. So common sense sorts of things. Now, why did we even think about doing this? Well, in part because what we noticed, and certainly Dr. Fuller deserves the credit for this, there was a lot of variability in terms of how patients in emergency departments were being ventilated. Even today, this occurs. And it probably hasn't changed that much on a global basis. But this was implemented, and this was done as a very simple quality improvement study, meaning that there were groups. There was the before group, which is sort of how things were being done, and then the respiratory therapy protocol, if you will, was developed, and then most importantly, it was implemented, and then the after group was evaluated. So what happened here? The groups were comparable. I mean, it was fairly large, about 1,200 in the before group, 500 in the after group. The main difference here was that the after group was a little sicker. The Apache 2 scores were higher. But when we look at what actually happened here from an outcome perspective, we can see here that did the protocol accomplish what it set out to do? And the answer to that is yes. You can see the two columns here, pre-intervention and the intervention group. If we just look at tidal volumes were quite variable. If you just look at the median there and the 25th, 75th percentile, 7 to 9, they're quite broad. And that means that some patients were ventilated with tidal volumes even above 9 cc's per kilogram. So a lot of variability, a lot of opportunity there because those higher tidal volumes are going to subject the patient to potential harm. You can see that once the intervention was put into place, those tidal volumes were standardized. I mean, the median was 6.3, 6 to 6.7. You can also see across the board there were changes that occurred, even simple things like keeping the head of the bed elevated, which you can't do in everyone and you can't do it continuously, but the point is that it went up dramatically from about 40% to almost 90%. And achieving a lung protective ventilation strategy in the emergency department went from about 50% to almost 97%. If we look at the variables down below, again, we can see that even once the patient was transferred to the intensive care unit from the emergency room, these changes carried over. So it makes the point that, yes, what's done in the emergency room or in a clinic, if you will, in this particular case, the ED, influences what can happen later on and carries over. And how do we know that? We know it based on this graph. You know, here we can see what happened in the intervention group. Those are the gray bars. And keep in mind that, you know, this was done by the therapists in the emergency department. This was their protocol, and then it was transferred over to the ICU group. And you can see here that the tidal volumes were pushed down from the higher tidal volume range to the lower tidal volume range. And what were the outcomes? I mean, this study, no one suspected that the results of the study would be as dramatic as they were. But what you can see here was that the occurrence of ARDS was lower. These were all patients who did not have ARDS at the time that they were intubated in the emergency room. VACs were lower. That comprised the composite outcome. Ventilator-free days were lower in the intervention group, as were hospital-free days and ICU-free days, although that did not achieve significance. But mortality was reduced from 28% down to 20%. It was about an 8% absolute reduction in mortality by changing a practice in the emergency department. Now, this is a before-after study. You know, obviously it's not an RCT, but it's a large study, and I think it provides really a good level of support for this type of a practice change. We also standardized this by doing a matched cohort, you know, having cases and controls, and the results were identical, even after controlling for things like severity of illness. The other interesting thing that came out of this was that the same protocol was applied to patients in the emergency department who had ARDS. You know, the prior one was for patients without, this is for patients with, and what you can see, the practices were equally achieved. The line at the top, the black line, represents the tidal volumes for those patients in the before group. They were higher, about 8 to 8.5. The gray line represents the intervention tidal volumes. They had dropped down to about 6 or so, 6.5. And the bars just show you how often patients were likely to achieve a protective strategy of mechanical ventilation while in the emergency department. And again, much higher in the intervention group. And like in the group without ARDS, in this particular study, mortality was lower. Mortality was higher overall because these were patients who were sicker, 55%, which dropped down to about 40%, an even greater absolute difference compared to the other. So we can see here in a very dramatic manner how implementing a protocol, in this particular case in a very sick group of patients, can influence their outcomes, and it really illustrates the role of respiratory therapy, not only in implementing and developing this practice, but very importantly in carrying it out. And we also know that, you know, the same strategy can be focused in other areas. This just looks at the operating room just to make the same point that when you use a lung protective strategy of ventilation in the operating room, where there is a tremendous amount of variability in tidal volumes, use of PEEP, et cetera, that one can also reduce subsequent pulmonary complications. So we know there are lots of technologies, things are evolving, even amongst our pulmonary fellows. Sometimes they're confused about, you know, non-invasive ventilation, AVAPs, you know, the use of various forms of high-flow oxygen therapy. You know, this is where standardization, protocol development come into play. And at least in my career, and I can remember when I was in the Army at Fort Lewis, we would have just a standard ventilator and a mask, and that was our way of, offering mask ventilation to patients when they would come in to the emergency room or to the intensive care unit. We didn't have, the fancier new devices that are available today, but the point is that technology has evolved over the last 30 years, and so has the literature. And this is just one meta-analysis. It's a recent one in critical care medicine, just making the point that even in hypoxic, acute, non-hypercapnic respiratory failure, there's now evidence that non-invasive mask ventilation can be associated with improved outcomes and potentially reduced mortality. And we know this is true for hypercapnic respiratory failure, particularly in COPD. We also have good evidence of this in congestive heart failure and pulmonary edema. And so this represents a huge opportunity for respiratory therapists within the hospital setting, again, minimizing the requirement for tracheal intubation, mechanical ventilation, and allowing for less intensive use of resources, but also at the same time improving patient outcomes. And there's also an important caveat here, and I think increasingly, we're seeing the use of protocols that are taking technologies like this and maybe using them in a more palliative way. We're not wanting to intubate the patient, we're wanting to provide less intensive care. So, we have that discussion going on, and palliative care is actually moving into the ranks, if you will, of respiratory therapy as well, particularly when it comes to the use of certain technologies. Okay, moving out of the ICU, but still focusing on protocols and their development. And we're now going to talk a little bit about respiratory treatments, respiratory care treatments. Again, to the average physician, I think it's confusing. Not every hospital has pulmonologists. Yes, more and more have hospitalists. There are lots of different therapies that come and go. I always have to keep track of this. Sometimes I still are thinking, okay, I need to order IPPB, but then I'm told, no, we don't have it anymore. And I think, okay, that's because I'm old and I need to start thinking about other things. But it's always an evolving format. And so we have advantages and disadvantages of protocols. Protocols can help to educate. They can also help to standardize. The advantages of protocols are that they're guideline-based, patient-focused. They can achieve greater cost effectiveness, and they can allow for better triaging of work and efforts. There always have been these disadvantages that some people have harped on, particularly a loss of autonomy, physician autonomy. But if you look at the evidence here, particularly when it comes to the use of respiratory protocols, those implemented and developed and carried out by respiratory care practitioners, there are studies show that they actually increase the knowledge base of non-respiratory care individuals, meaning, the physicians, the nursing staff who are working on the floors or the outpatient areas where they're being implemented. So this idea of autonomy, I think, is a false one, and if anything, they help to increase the overall level of understanding. And the outcomes, as I already alluded to, are generally better. I just show this because this was an interesting one that was developed at Barnes-Jewish Hospital. Darnetta Klinkscale, who just retired this year, was a lead author here. But the idea here was that we had a new technology at the time, if you will. It was a vibrating vest. And we just wanted to see how well did it do against, the gold standard. And so this was really a non-inferiority study. The idea being that, can we alter or evolve the way certain treatments are done by respiratory care practitioners in the hospital setting. And the bar graphs here just represent the hospital stays for patients who underwent conventional chest physiotherapy versus high-frequency chest wall compressions. And they were comparable. So there didn't appear to be any downside from this, maybe a few less cases of carpal tunnel syndrome in some of these individuals. And then overall survival was the same as well. And when we looked at patient comfort, we found that patient comfort scores were better. Those patients that got high-frequency chest wall compressions, their comfort scores were lower, indicating they tolerated the procedure in a more favorable way. Now, everything's not rosy, because even here we learned that if you had lobar atelectasis, your lobar atelectasis was more likely to improve more rapidly if you underwent conventional chest physiotherapy, but the overall outcomes seem to be the same. So again, it just illustrates how respiratory therapy can look at new technologies, look at new procedures, and find ways of implementing them in a very efficient way. Dr. Stoller and colleagues at the Cleveland Clinic a number of years ago looked at something which today we take for granted. And I think there are many other things that are being done today that 5 or 10 years from now we can look back and say, oh, we are taking that for granted. And we were just talking here a moment ago about ECMO and how, is there a role for respiratory therapists within ECMO? And certainly there is, from the standpoint of managing ventilator, managing patients, particularly with VV ECMO being used for patients who have more of a respiratory failure component. But in this case, going back to about 1996, the idea was oxygen therapy. And today we have no problems having oxygen therapy weaned, started, turned off by a respiratory therapist without someone having to write an order in the chart. This was actually the protocol that they looked at back then. They had standardized it, very similar to protocols in many of your institutions. And these were the outcomes that they identified. So hospital lengths of stay, no different. Mortality, no different. Treatment modes, really the same. Everything seemed to be similar. So again, they demonstrated that compared to a physician-directed approach, the use of respiratory therapists guided protocols for utilizing and weaning oxygen therapy was similar. So it's safe. And this is very similar to the weaning protocols I showed earlier on mechanical ventilation, the same idea, the same types of strategies. But what they also found was that when they looked at this, how frequently were these recommendations made by either the physicians or the therapists in line with the protocols based within the institution. And across the board here, one can see that stringent utilization or mapping, if you will, of the outcomes to the hospital protocols were stronger with the respiratory therapy group compared to the physician group. This is an example from our own institution where we did the same thing now, going back about 18 years ago, but not just focusing on oxygen therapy, but really looking at all respiratory care treatments. And I can remember, before we did this, we sat down and we redid all the respiratory therapy protocols through the department. I mean, it was a huge effort carried out by a number of individuals there. And the protocol that I'm showing you here, and it's not important to focus on it, but it's really the one dealing with bronchial hygiene, and it's evolved since then. But the idea was, and the way we did this was very simple. We had 3 firms in the hospital for internal medicine. These were hospital floors. There were a couple of them in each firm that were managed by different physician teams. And so what we said was, okay, in firm A, we're going to change things so that the respiratory practices, treatments are carried out by protocol by the therapists. The physicians are not really going to be writing the orders here, whereas in firms B and C, we continue to do the traditional approach. And what did we find? Okay, one can see there that when we looked at the respiratory treatments, firm A had significantly fewer compared to the other firms. So we were carrying out fewer treatments. Now, maybe the hospital administrator might be happy with that if it reduces costs, but we want to be sure it's not affecting clinical outcomes. And indeed, patients had no ill effects from this. When we look at the bars on the other side in terms of small volume nebulizer versus meter dose inhaler, we can see in firm A that there were less use of small volume nebulizers and more use of meter dose inhalers, which at the time really was sort of a transition. It's interesting because now, at least in our system, and I don't know if it's true in many of your own systems, we're going back in time. We're going back in time to using more small volume nebulizers because there seems to be a cost savings with them, even though it may take a little more time from the standpoint of the respiratory therapist carrying out the procedure. So it's interesting to see how these things will evolve based on the pressures that are acting on them, and now it's more of a cost pressure from an acquisition cost. In that particular study, when we look at the firms, overall, the only difference that we can find was that the respiratory care charges were lower in firm A. So fewer procedures, less charges. And one of the key things I think that came out of this, and Dr. Stoller's study from Cleveland Clinic brought this out, when we looked at discordant orders were orders for respiratory therapy that were written that were not in line with the hospital protocol. That's where the increased costs were associated. And there were significantly fewer of those discordant orders in firm A. So here's another good example where respiratory therapy could step in, standardize the approach to treatment, in this particular case, inpatient, treatments and not only result in good clinical outcomes, but overall reduce costs to the center. Now I'm going to move on to more of an outpatient example, and I think there are many, many examples here that we could cite, but I'm just going to focus on one, COPD disease management. If you have looked at the literature for the last 10 to 15 years, there's been this increasing momentum to try to develop disease management programs, to try to keep patients out of the hospital, number one, but also improve the quality of their life by reducing exacerbations, the need for emergency room visits. This is true for congestive heart failure, for diabetes, for any chronic disease, and certainly COPD fits into that paradigm. And so there are many aspects that fall into this: how to use their inhalers properly, smoking cessation, obviously good exercise, pulmonary rehabilitation, the use of oxygen, the use of nocturnal BiPAP or CPAP, if you will. It becomes a very complex multimodality approach, and someone has to sort of oversee this. And many times there's not enough time when the patient goes into a clinic for a visit to go over all of this. The idea is that education has to occur, and this is, again, one of our therapists in our hospital providing education to a patient with COPD prior to being discharged to home. And we all do that, but is that enough? And you know, the literature is quite mixed on this, and this is another area where I think we need more work, and we need to figure out what works best, because there's a lot of opportunity here. And for better or for worse, you know, chronic diseases, including COPD, is not going away because, you know, of smoking and occupational risks, et cetera. This is actually the study done by Rice. The first two studies I'll show you are VA studies. And the idea was that, you know, we could take a chronic disease like this with input, strategic input from respiratory therapists, develop a disease management program. And this particular one was focused on outpatients. These were patients who had either had a COPD admission or had been in an emergency room. They targeted them within a clinic, and then they put them through this program, which also required some education as well as some follow-up calls. And you can see that even though it was somewhat of a smaller study involving 5 sites, the numbers of patients that required a hospital and or ED visit dropped significantly with this intervention. So, I mean, that was good news. It suggested that, you know, one can take these patients, sort of identify them at high risk, implement this program, and potentially improve their outcomes. And this just shows across the board, when you look at these subgroups, regardless of age and other factors, it seemed to work. Well, unfortunately, there was another VA study done. Again, and this one was one that was more outpatient-based. These were patients who had been hospitalized. They were identified in a clinic. They'd been hospitalized in the previous year for COPD. We know that's an important risk factor for subsequent morbidities and comorbidities, as well as hospitalization, and it was done in 20 centers. And again, you can see here that respiratory therapists played a very important role here in terms of carrying out the protocols, the interventions, which included education, feedback, follow-up calls. But in this particular case, the study was stopped early. And it was stopped early because when you look at the mortality graph in the bottom, even though hospitalizations did not change with the intervention, which is different than the prior study, mortality was higher in the intervention group. And that's why the study was stopped. To this day, no one has been able to offer a good explanation for why this occurred. It could be a chance phenomenon, I mean, which happens in certain trials, where because of the way patients are selected, you know, you're going to have a worse outcome that's not expected, but that was the finding here. So in a way, this sort of set back this whole idea. We actually, and Patty Silver, who's here as the lead author on this particular study, did the same thing at Barnes-Jewish Hospital. This was a huge undertaking, a lot of effort, where patients had to be identified in the hospital with COPD. They were offered an educational program with the intervention group in the hospital. Then they also had, you know, regular follow-up calls that were conducted at day 7 to 10, 30, 90, and 180 days after discharge which went over things, potentially assisted in things such as where they could get meds, where they could get follow-up appointments. And in this particular randomized trial, the outcome was more similar to the RICE study, the first one I showed you. It was a fairly intensive program requiring a lot of resources from the respiratory therapy department, but overall the numbers of patients requiring a hospital visit or an emergency room visit over the next 180 days was lower. So the issue becomes, is this something that we want to do? And if we want to do, will hospitals invest in this kind of a program? And if they do, one has to identify what the benefit is potentially to the hospital. And based on the RICE program and the other one from the VA, each hospital or each system has to sort of evaluate these on their own, because we don't know yet, which of these elements are most important for optimizing the outcome. In this particular program, the main thing that we focused on was subsequent COPD admissions or emergency medicine visits, and they were lower, even though overall mortality was no different, overall numbers of hospital admissions were no different, because hospitalizations for pneumonia, heart failure, kidney injury continue to occur. One of the last things I'll touch on is just the idea of acute care teams. And acute care teams have evolved. I sort of gave you the example of the emergency department. Increasingly, acute care teams are being used in hospitals, not just in the US, but throughout the country. It's something that, and in fact, globally for that matter, places like the UK, Australia have really sort of led in this development. And at Barnes-Jewish Hospital, the acute care teams are variable, but we have nurses, respiratory therapists, some physicians that are involved with them depending on how severe the patient is. And these are patients on a general floor or ward. Now, in our own system, and I'm not going to belabor it, we developed this automated early warning system for developing these patients using a certain number of variables, which I'm not going to go into. We've done a number of trials with them, such as this one, where we have an alert. The alerts are run 24/7. If the alert goes off on a patient, then the rapid response team is notified to go evaluate them, and we've demonstrated that we could reduce, for example, hospital days in this type of a situation. But, why? And the why is that the individuals that get called in to see that patient, whether it's the acute care nurse, respiratory therapist, sometimes even the physician, they have this reminder, they go in, they assess the patient, and certain therapies may be administered, including things such as oximetry, telemetry, antibiotics, et cetera, but many of these are respiratory in terms of their origin. And so it really represents an important way of channeling some of the efforts of respiratory care practitioners in that particular situation. These are just data from our hospital, starting from about the time that we implemented our early warning system along with the rapid response teams. And on the hospital wards, the percentages are small here from 3 to 2, but we're talking about thousands of patients on these wards per year, and the mortality has clearly dropped as this has been implemented. Not only that, but when you look at the solid lines, the solid line represents the number of cardiopulmonary arrests on these floors. The dotted line represents the number of activations. The majority of these, more than 60%, are respiratory events. So really, again, highlighting the importance of the respiratory component here. And you can see that as those rapid response calls go up, driven in this particular case by the early warning system, the cardiopulmonary arrests have dropped significantly, and the hospital lengths of stay have dropped as well. So again, it's a win-win. So I'm going to summarize a little bit here, and then I have a couple of other slides that'll follow up on this. But I think there are multiple areas that can easily be demonstrated where respiratory therapists have added value to the healthcare system. The evidence is clear on that, both on the inpatient side, the outpatient side, and I've tried to touch on some of those. Obviously, we need more research, really more pragmatic research to try to further this along and show, exactly where else advances can occur and where else can the value of respiratory therapy be recognized in the healthcare system. And I think, as others have said, the professionalism in respiratory care must continue with standards in education, competency, administration, and research. An area that I don't spend a lot of my time on, but I think in the future will increasingly be important is pulmonary rehabilitation. With advances in our knowledge of exercise physiology, I think this is really a key area that has already grown, but will continue to grow. We've had some therapists actually move into infection control as well, another very important area. For our institution, I think this is important because the U.S. is sort of a leader in this area. There's a lot of opportunity for education. And I just show this. This is an exchange program we have with Hong Kong where they have a little, they just don't have the sophistication, if you will, that we do in many of their community hospitals for respiratory treatment. So we have the opportunity of using our knowledge and expanding it globally. St. Louis, 4th of July, if you're there, it's a great show. Don't miss it. And with that, I'll stop, and if anybody has any questions, I'll answer them. Thank you.